I'm your VP of Education for Medic Mentor. We're going to try and get Sherry-Ann in right at the end, but I'm going to go through the stream for the medicine part of the study guide. So Sharon has already very nicely gone through the dental part. I learned a lot from Sharon there. I'm pretty sure a lot of you did as well. So she's already done a great job. She's already outlined the case for us really nicely. So I do have a slide. I have some slides to share again for you. I always think it's a bit easier for you guys. Now, I know we had a bit of a problem with this last time. So let me see. If I can't get them, it's okay. Just seeing. Yeah, I'm afraid there doesn't seem to be an option to share my slides or share my screen. So it's okay. No, that's fine. So with the case, the case was a young boy with asthma and got into quite a scary situation. So asthma is very common in young people. About 1 in 11 children have asthma, much more common in boys than it is in girls. It's asthma. There's a lot of factors that can contribute to asthma. There is a genetic component, sort of an atopy component that we call, where people are predisposed to allergens that can trigger asthma, eczema, hay fever. It's like the triad of atopy. So genetics is a factor, but there's also a lot of other factors, a lot of environmental factors that contribute to asthma. And it's a whole range of things. It can be things like animal fur, it can be mold, it can be things like exercise, hormones, more so in women than men, can trigger asthma attacks. Different types of food can trigger it. Stress is a big factor in your trachea. You have a lot of immune cells there. And the reason they're there is because when you breathe in, although the air looks clear, there's actually a lot of contaminants. And basically, if those contaminants were to go all the way down into your lungs, that would trigger an infection, which your body couldn't cope with all the time. So your body has lots of immune cells in your airway. And these immune cells are constantly vetting the air that you're breathing in. And say you were to breathe in some pollen or something like that. Now that might, what happens is that your mast cells, which is a form of immune cell, basically sticks that pollen to its cell surface. And then it sort of takes that pollen into the cell, processes it, and then produces antibody. These mast cells that previously recognized the pollen then express antibodies that recognize this pollen. So when the pollen binds to it, you can potentially get a massive inflammatory response. It's a massive allergic reaction. And, that's how anaphylaxis is caused. It's how, how the asthma is caused as well with the eosinophils. So the eosinophils are the cells that tend to express the antibodies. Now, therefore, an asthma attack can be triggered at any point in time in somebody who has asthma. And it's very serious. There are different ways of grading asthma attacks. That was one of the questions. So in adults, the way we do it is we have moderate, severe, life-threatening, and near fatal. And basically, it's gradations of how severely unwell the patient is. And one of the big factors that comes into grading asthma is the peak flow. So you can look up what a peak flow meter looks like. It's basically a tube, and then it's like a tube that you breathe into, and the force at which you breathe into it gives you a reading. So if that patient is ventilating well, breathing in and out well, they're going to be able to give a big breath out, a big exhalation, and get a decent peak flow. If, however, their chest is full of inflammation, full of secretions, their airway is tight because of this inflammatory process in the asthma, they're not going to be able to exhale very well. And when peak flow is sort of 33 to 50% of predicted, or what their normal is, then you really start to worry about them. Other big signs in children of respiratory distress, you tend to get recessions of the chest, and that's one of the most common signs, is use of accessory muscles. You get subcostal recessions, you get phlegm, what we need to do, what treatment, etc. But any child in respiratory distress needs urgent attention, needs urgent treatment, and if it's severe enough, should be admitted to hospital via pediatric ambulance. So in this case, going back to the case, so this young boy, Thomas, got a dog for his birthday, and as lovely as that was, unfortunately, it would have been the dog hairs that he was allergic to, essentially, and that over a period of time, he starts to develop symptoms towards. So very classical symptoms of chronic asthma, of like developing asthma, is like a cough at night time more than anything, wheezy, like they all sound like they have a wheeze on their chest, and they often, their chest feels very tight, which makes sense because of this reaction to the allergens in their airway, they're producing secretions. That's the first thing. So they've got a lot of mucus in there. Their airway actually contracts, like a bronchoconstriction, which is like a vasospasm, like a reaction to the inflammation. And then you've got the inflammatory cell infiltration as well. So it's three factors that lead to asthma, and when all of those come together severely, then you get an exacerbation of asthma on top of the chronicity. So in this case, this young boy, he came in to hospital very unwell. He would have been treated with high flow oxygen. The first thing that our British Thoracic Society guidelines, which is our gold standard for managing any thoracic disease, any chest illness in the UK, essentially. So they have guidelines on asthma for adults and children. And for the children, they recommend one of the most important things you can do is give that child steroids when they first come in. And the reason for that is, bear in mind, steroids take a bit of time to work, so they can take a few hours to really, actually start working. And the sooner you're getting the steroids into them, the sooner you're reducing that inflammation on the chest, and the more likely you're going to be able to help them to breathe. So the steroids are important, although, get them in early, although they're not going to take effect immediately. The treatment that is going to take effect immediately for the child in respiratory distress is inhalers or ideally nebulizers. So nebulizer is basically a device that what we use is things like salbutamol, which is a short-acting beta agonist, essentially helps to relax the airway up. So that's one thing. And then also ipratropium bromide we use as well, which is an anticholinergic. Again, trying to get over this inflammatory response. So they're the two nebulizers that we use principally, and we use them very commonly. So back-to-back sort of treatment to get the air flowing and the airway opened. Now, we then there's a period where we will see how the child is coping with those into a treatment option to demonstrate that it's efficacious, so effective, and that it's safe beyond reasonable doubt within the research studies. And then once you have that for a treatment, there's no significant adverse side effects, so the benefits outweigh risks, then the guideline committee, which is comprised of experts in the field, so may include some researchers, consultant physicians, surgeons, etc., will come together and decide if that research base should be brought into clinical practice guidelines. So that that is the difference. And when you go to study medicine, it's very important that you're very careful about the sources that you get your information from. And usually going to the guidelines is your absolute best bet, because that is how we practice medicine. You could ask any respiratory consultant and they would ask you to quote BTS, British Thoracic Society guidelines. So in those guidelines, what it says is you can now. There's in asthma, there is an elixir of life, which I was always taught at medical school, which is magnesium sulfate. Now we use this in other instances, other very like life-threatening instances, but in asthma, it's actually particularly effective. Now it's not without its risks, so we try and see if they can tolerate the treatment I've already described. But if not, then you might consider starting magnesium sulfate infusion over usually a 20-minute period, and then you monitor during that time, monitoring heart rate for arrhythmias, etc. But it's often a bit of a wonder drug, so we do use it from time to time. Now in this young man, now he really was very sick. And he actually went because of if you remember in the case, he had what we call a capillary blood gas. Now in children, we can do this. So you basically, so you would prick the tip of their finger with just a very small needle device, get a little blob of blood, and then you basically get this. It's like a big plastic tube about that long, and you basically suck the blood into the tube. It just does it automatically, like it vacuums it out. And then you can work that as the capillary blood gas. Now, that's what we usually use in children. In adults, we prefer to use what we call an arterial blood gas. So it is, as it says on the tin, so you usually feel for your radial pulse, so you can feel it there just beside your thumb. It should be really strong in all of you healthy young people. And we basically, in adults, get them to cock their wrist back like that, pop a needle in where we can feel the pulse and then get a sample out. Now, we call them ABGs, arterial blood gases. They are one of the most useful pieces of information when a patient is sick, because it gives you so much information. So it will tell you what their pH is in their blood, and if they're acidotic, if they're a bit alkalotic, or not, normal. It will tell you what the level of oxygenation is in the blood. So if it's low, and that CO2 might not be released or exchanged as well. So those are crucial in anyone who's ill, anyone with a significant respiratory disease. And in that case, in the case I gave you, so you will notice that the oxygen was very low, and the carbon dioxide was a little bit borderline and a little bit higher than within its normal range. Now that is what we call life-threatening and actually near fatal asthma, because that CO2 is beginning to rise up. You're beginning to get this acidosis, or respiratory acidosis, and the patient really is not, they're not breathing properly. They're starting to tire. And when that happens in asthma, then you risk them going into an arrest situation. Now, this young boy sort of had a respiratory arrest and then triggering a cardiac arrest. So principally in his case, because of hypoxia. Now, hypoxia is one of the reversible causes of a cardiac arrest. The other sort of reversible causes you can think about is potassium's an important one as well, but in this case it was the low oxygen. So went into cardiac arrest. So when any patient goes into cardiac arrest, it's when you run, you dive in. You need as many hands on base as you can possibly get, because seconds absolutely count. Now the CPR for children is slightly different from adults. So when you see a child gone into arrest, and you've checked for breathing, no response, no respiratory movements, no central pulse, so usually a carotid pulse, then what you need to do is give 5 rescue breaths straight away, and then you do your 15 chest compressions to 2 rescue breaths. Now, in a hospital setting, rather than giving actual rescue breaths mouth to mouth, we tend to use like a bag and valve mask for the time being, until we get further help. Now, in this case, so this boy, after a couple of cycles of CPR, so he had sort of spontaneous return of circulation. So he didn't need any drugs in the meantime. Basically with the cardiac arrest protocols, that they have to look at the pulse and the rhythm of the heart, and it depends if it's if you can or cannot give medication, basically. So in this case, he didn't actually need medication. But he needed rapid sequence induction, which is a whole other entity for another talk, to be honest. But it's basically where you're anesthetizing a patient, not in an anesthetic room, essentially. So it is complicated. It has to be done, by a consultant anesthetist, usually in liaison with an ITU consultant. We're talking the top end, the most senior people, and then it's because of risk of aspiration. That's the biggest risk with rapid sequence induction. So this young boy, inhalational pressure and exhalational pressure to ensure that ventilation is adequate. And the beauty of ITU is the amount of very easy monitoring you can do. Usually people need some sort of central venous access, may even need arterial access in some cases in an ITU setting. But because I when you as a medical student, you'll all get some ITU experience, and it really is incredible experience. You do see the sickest of patients, and it is scary, but it's also wonderful to see. It's really is medicine at its best, and they do say that the UK has the best critical care in the world. Our emergency care is some of the best. So it was I hope it was a very interesting case for you. Asthma is a very common condition, very scary when they become severely unwell, as this young boy did. And I think in this case, now that he's had a life-threatening, near fatal exacerbation of asthma, he would then need to have review with the consultant paediatrician specializing in respiratory medicine. He would need long-term inhaler therapy, so that usually consists of initially like a salbutamol, so short-acting beta agonist, if he's symptomatic. It would include also usually a long-term steroid, which is inhaled, at least initially. We try and avoid long-term oral steroids in any young people, anyone really, because of the significant side effects. But however, the inhaled steroids are the risks, and you don't get the same side effect profile with them. So that would be typically what he'd start on. He would also have like an aero chamber, which helps the diffusion of those inhaled drugs. And that's the beauty of asthma and respiratory treatments, is they're so localized, the effect. And it certainly need intensive follow-up, regularly peak flow measuring to make sure that he's back and he's stable, and and not at risk of developing another exacerbation of asthma, essentially. So that was the case bit. I'm just having a quick look at the questions. What is aspiration? Oh, I'm sorry. So aspiration is where basically food goes down the air pipe rather than your esophagus. So it goes down the trachea. And the problem with that is, it can go into, if it starts to creep into the lung, it will then attract bacteria, bugs, and then you can develop a chest infection and pneumonia. Aspiration is, so anybody who is essentially, if you're unconscious, you can't maintain your airway. And that's why you would be advised, anyone who's unconscious, to put them in a recovery position, because then if they need to vomit, it will come outwards and not back down into the trachea, essentially. So aspiration. I'm working on stroke at the minute, so we do space. So let me just bring it up for you. Okay. So I'm just going to go through it very, very briefly. Okay, so this is a Monday morning. You're the foundation doctor, so like myself, first year medic. When one of your patients calls across the room to you, you haven't actually seen him or really met him yet, and he's been worrying all weekend, basically, and he says to you straight up, "Has my cancer come back?" Now, it's a very difficult situation, especially as a first year doctor, to be in. Now, you've got all the answers there, so I hope you had fun trying to figure out the order. But basically, in principle, when a patient asks you a question like that, it is always advisable to go back to their notes. You need to have a clear picture of what's been done, what's outstanding, what further investigations need to be done. You need a clear idea of treatment pathways and what the plan is from a consultant, or at least a senior registrar, a senior doctor. And you need to assemble all of this information very clearly in your mind before you go and see a patient. Now, there will be some things you won't know. And again, that's working in the limitations of your knowledge and expertise. But to give the patient the best chance of giving them that news, you need to be well informed. So in reality, when a patient asks you that, actually going there and blurting out anything or what you can think of, it isn't the right thing to do. You need to be honest with the patient and say, "I need to look into this a bit further. I'd like to discuss this with my consultant," etc. And it is buying time, which is important in a circumstance like this. So I think certainly C would be the most appropriate, as you can see there. Now, of this, so you could probably tell in these answers there was some highly inappropriate things to say, like, don't even be worrying about it, or you can never lie to a patient, or you would all know that, and you can't falsely reassure either. You have to be honest. And I mean, as a foundation year one doctor, you're very much technically a supervised role. So if you do your SJTs in medical school and you get asked a question like this, technically as an F1, you shouldn't really be breaking the bad news yourself. It should be a senior doctor. And by all means, I would encourage you as medical students and juniors to sit in with seniors who break bad news, to learn what their style is, how they do it. But so in reality, you probably shouldn't be breaking bad news, but it's sometimes a bit more difficult than that. And sometimes you do have to break bad news, and your consultant will ask you to do that. And you have to be confident about it. You therefore have to know how to break bad news. I think we did touch on this in a previous SJT, so I don't want to labour it too much. And for those of you who were there at the weekend, Dr. Pegg went through this very nicely. She had a really nice A to E system. Now, in medicine, we tend to use it's called a spike system. So the S is the setting. So if you're going to have a discussion with a patient and family about bad news, you don't really want to be doing that on a busy ward. You want to give that family some space. So try and take them into a separate room. Try and have another member of staff there, one of the nurses, one of the cancer nurses, if that's appropriate, just to provide that extra level of support. P is sort of the perception, what the patient already knows, and that's really important, and I is the invitation. So does that patient actually want to know at that point in time? And some patients will want to know straight away, but others will say, I want my family to be here, like I can't do this on my own. So you must ask, if they're ready to, if you're ready to discuss it, if they're happy. And then you've got the K is sort of the knowledge, what they know already, and ask them to tell you that, so you know where you're pitching at, you know what level of detail to go into, you know what you don't need to explain again, basically. And then the E of spike is sort of your empathy, and making sure you give adequate pauses, giving time to let the information sink in. It's being honest about what the issues are, and patients will always ask you, how long have I got? And you can't really ever give that. You can ask your consultants if it's weeks, months, or years, but really that's the extent. So you sometimes it's okay to say you don't know. And then S is I think of it as the solution. It's sort of what are the next steps? What is the plan moving forward? What scans need to be done? What follow-up does that patient need? What treatment options are you going to provide? And you need all of that needs to be in place before you even embark on a conversation about bad news. I've been asked on my own calls to review scans and things, where the scans are reported as a cancer having widely metastasized, widely spread around the body. I've looked at that scan at 8:30 at night, and you kind of think, this probably isn't a good time to tell that patient they have cancer. Their family aren't there, they're going to be on their own all night. It's something that can potentially, you can delay it. That's part of your professional role, is deciding, do you need to delay it? Is it appropriate perhaps to delay it for as long as it's in the best interest of the patient? So it's always, bad news is always a very difficult conversation. It is one of the worst things you have to do in the job. I'm not going to lie. You do feel emotionally connected to the patient and the family, and when the family are there, it's horrible. But you have to be strong for the patient as well. You have to be that voice for them, for any questions that they have, and that's what the family will appreciate. Okay, so that's the SJT. So I hope you enjoyed going through that. Now the next bit for my medicine, I'm a little bit conscious of time, was the debate. Now I quite liked putting this debate together, actually. So the debate, for those of you who might not know, is all about NHS past and present. And when you go to medical school, you will always have lecturers who talk to you about the birth of the NHS, and what a wonderful entity it is. And I working on the front line of the NHS, I can truly say what a wonder it is every day. I was speaking to a colleague today who was working previously in Uganda, and patients would come to him, he would suspect a stroke in them, but he'd have no idea if that was a stroke because of a bleed on the brain, so bleeding, or because of infarct, so lack of blood supply. Now in the UK, every patient who comes in that we suspect having a stroke, we do a CT head scan. We're basically looking for any signs of bleed on the brain. If there isn't a bleed on the brain and the patient is suitable, then we try and thrombolyze. We try and clot bust, basically get rid of that clot that is blocking blood supply to that part of the brain and leading to the symptoms. Because even though there'll be a part of brain that might be sort of dead or dying, there will be a surrounding part called the penumbra, which is that area of brain that has a chance of being saved if you can unblock the pipe, basically. So that's what we do in the UK. That's what I'm doing at the moment on stroke, as part of my team. But this colleague I was speaking to in Uganda, his patient came, he thought it was an infarct, stroke, a lack of blood supply because of a clot rather than a bleed. So he gave an anticoagulant agent, and actually it turned out that it was a bleed on the brain, and that patient actually suffered far more because and it was simply because he couldn't do a CT head. You can't just request a CT head in other countries. We are so lucky, we are so privileged in this country to have the NHS. It's the staff who work in the NHS. We do work tirelessly, and it's sometimes it's against the odds, and it's sometimes very busy days, but it's because our hearts are all in the right place, and that is the beauty of it. I think you're so lucky as a medic. It's such a privilege to work with the group of people that you work with in the NHS, because there's very few other professions that are all in it for the people they serve, for their patients. Most other professions especially, a lot of people are in it for themselves or for the finance, and that's not what the NHS is about. Now, the NHS was established in 1948, and it was established by an MP at the time called Bevan. Now, Bevan, so he is the father of our NHS. And it was his policy that essentially a country can't call itself civilized if it doesn't care for its weakest or its most unhealthy or most sick. And I think that is a beautiful phenomenon, and to this day the NHS, the care that's provided, is free at the point of delivery. So we don't, an ambulance doesn't turn up to your door and ask you for a credit card like it would in a lot of European countries, and other countries. So the American healthcare system is much more insurance based. So individuals have to take out their own health insurance. Depending how much they put in determines how much they get out. Whereas the NHS, it's free for everyone. We pay our taxes, and it's what we get in return. So when the NHS was formed in 1948, it was incredible. It was literally life-changing for hundreds of thousands of people. People could get, at the start of the NHS, you could get free glasses, you could get free hearing checks, you could go to your doctor whenever you wanted, for whatever you fancied. And so they were giving out glasses so frequently, and people were having different frames so often, and there was such demand on it that within a few years they had to get rid of that. They had to get rid of the eye care element and make people pay for that. But that's what it was like when it started. It was literally supposed to cover everything. And I think over time, the NHS has seen a lot of changes, in its structure, its organisation. Now, the NHS is essentially sort of regionally established. So, and the King's Fund, I had this diagram in my PowerPoint. I have a really nice diagram of the structure of the NHS, and I say nice diagram, it's a very complicated diagram. But so it was roughly about the time I applied to medical school in 2012 that the structure changed, and they went from sort of primary care trusts, which was your GPs, and your hospital medicine, which felt there was a massive divide between them. So they brought in this new structure called the Clinical Commissioning Groups. Now, the CCGs for short. So the CCGs are made up of principally GPs, but they also ask specialists from the hospital, from different specialties, to sit on the panels. And they decide on on funding for a lot of treatments, for referrals, etc. They sort of set the criteria that determines whether a patient is eligible for an investigation or treatment, etc. And the reason this was brought in was because it was to try and help the primary care who, are the gates to the NHS essentially, and try and improve their ability to, refer patients in, control expenditure of secondary care so that, primary care has sufficient to be managing the front line. And, so it's been established for a few years now. And it doesn't, day to day, most things you can prescribe, you can order scans. It doesn't limit that. It's more the expertise, the specialist drugs and treatments that it can inhibit or access to. Things like chemotherapy, special like in diabetes, certain insulin treatments, in like immunotherapies, those sorts of specialist treatments, not your standard treatments. So that is the new funding structure, and NHS England is essentially what oversees this. And I mean, there is, I'm sure you will have heard in the news about sort of the divide between health and social care and what a massive divide it is, and it does lead to a lot of problems. I'll quite happily say that. I think the plans have always been to try and bring health and social care together more and more. And it would really help. I mean, the social care side of things is when we talk about social care, we're talking about people living in sort of under the council, so people with, for example, learning disabilities, people in mental health sort of institutions that aren't hospitals. All of that is sort of your social care, if you like. It is a big, I'm not going to lie, it's a very, dealing with social care is very challenging sometimes, and we get very frustrated as doctors that we want to send patients home and we can't send them home because they don't have a bed in a rehab hospital. So it is frustrating. But I think moving forward, there are certainly plans to try and integrate health and social care better than it is currently. And one of the questions I posed in the debate was, what will the NHS look like in 10, 20, 30 years' time? And it was a bit of a sort of red herring question because nobody knows is the answer. And I'm sure you've heard from the news about the plans for privatisation and the implementations of that, what that will mean. And I think in reality, nobody wants to change the NHS, basically. But the issue is the funding, the demand, the supply can't really continue as it is. Patients wait 18 weeks for appointments, and when they shouldn't. That's not our guideline standards. There's always bed crises in hospital, particularly in winter. And I know the government has recently pledged a lot more money to the NHS, but the question is it enough? And I think actually what needs to happen is we need to become more savvy about the way we spend the money. We need to be more aware of what we're doing, why we're doing it. And I think there's certainly a role for that. I think sometimes we are a bit wasteful in the way we approach our practice in the NHS, because we are in the UK. For example, today, for how many patients I was looking after today? Probably about 10 patients. I ordered 5 carotid ultrasound scans. I ordered 4 MRI scans. I ordered 2 CT heads, and it's an incredible amount of imaging, and we just do it, and it's indicated, like, the patients need it, but the wastage. I think sometimes we are a little bit guilty of overusing investigations, and I think perhaps moving forward, we need to become a bit more mindful about what we do, why we do it. I heard a term today called vomit, which is victims of modern imaging techniques. And that is where we image somebody because they have a bit of pain, and then we pick up on a tumor. And what do you do with that tumor? It's not causing them any bother. Technically, it's not really causing the pain. Do you biopsy it, which is a risk? What do you do with it's something that you wouldn't have picked up on? It's an incidentaloma. So I think that will be interesting, and I hope that medical schools get on board with this and try and make us think about everything we do. Is it really needed? And I think perhaps we need to take that approach a little bit more. I think, as future doctors, all of you, you don't need to worry. You will always have a job. I'm always offered shifts to do at the weekend, late, if I want to, on top of my job, my working hours. So it's you will always have a job. The job security in the NHS is fantastic. The NHS as an employer is fantastic. Its pension is one of the best that there is around. They will support you in sickness and in health. So in that respect, I could never tell you to do medicine because of the money. Yes, there is incredible financial security, but it's too hard work for what you get paid. You're not on a banker's salary. You're not on potentially a lawyer's salary. You're on a very, very good salary. I'm not denying that at all. But it's for an incredible degree of responsibility. So I think that is important to consider. If you should never go into medicine for the money, that is an entirely wrong reason, and you will be disappointed, and you will walk away if that's your reasoning. And I hope we've given you enough reason to do medicine, not because of that. It's because of the incredible rewarding nature. It's incredible to see patients from I saw a man today who was literally like a miracle. He came in with a stroke. He came in with right-sided weakness, meaning could hardly move his arm and leg, and facial droop, slurred speech. Came in, had a CT head, was thrombolyzed, and today he was fine. He had absolutely no weakness. And that's sort of 1 in 8 to 1 in 10 patients actually get a full recovery following thrombolysis. So he is a very lucky man, and that is a miracle, and that is thanks to modern medicine. Our research practices moving into guideline practices, clinical practice. That is incredible. That made my day, like just seeing that. So I can't tell you enough how rewarding it is, despite the challenges. So I think that was almost the question of what it will look like, was just to make you think. I talked a little bit about the role of technology, which we're actually very bad at embracing in the NHS, and it's because of money. Technology is expensive. We all know that. And when you want the next smartphone or the next laptop, we're talking about a lot of money, and that's why there isn't room for investment. There isn't enough investment in the NHS with technology, and they've talked. My friends have talked about, and colleagues, about like AI and artificial intelligence, and how it's going to take over doctors, and they're not going to need doctors anymore. You're just going to see a robot. I am a firm believer that we will still need doctors. I do consider myself better than a robot, and yes, I'm susceptible to human error, but I think AI could certainly help us, and I think it would be really interesting to see how, and if we do start integrating it into practice. I think that's really exciting. It's a great time to join the NHS. I know there's a lot of change, and there will be over the next few years, especially with what's happening next month. But I hope with it's certainly a worthwhile career, and I can't convince you otherwise. It's fantastic. So I would certainly keep at it if I were you. So that my last article was about life as a junior doctor. So I hope you enjoyed that. And then I'm a little bit conscious of time. I was going to talk about wastage in the NHS, which I've already touched on. Now, Sherry Ann was going to do her veterinary bit. I can see lots of questions, which is really good to see. I know Dr. Seaver's doing really well. I think certainly as part of these webinars, I can see a lot of the questions around the medical school applications. So if so I can certainly do a little session on that in one of these webinars and just enlighten you with my experience of it. I did see one question that you were saying, I don't think I'm bright enough for medical school. And like everything I've just talked about, I've learned over 6 years. It didn't happen overnight. I didn't start medical school on day one and know all of that. It's just honestly, it's I always used to hate this saying, but you are like a sponge. You do just sort of take it all in, and the more the time you spend on the wards, the more you read about, the more it just comes very naturally to you, and it's wonderful. Like it's always so fascinating to learn about medicine. I love medicine, every part of it, and I don't want you to worry. Like you don't have. I am 7, 8 years ahead of you guys, so you don't have to know everything I know. It's just the aim of the PBL is purely to enlighten you a little bit and spice up your interest for medicine and see what it's like to have a case like that and to go through it. So I don't want you to worry about that at all. And certainly, I think we can go through. I think it might be nice to do a little bit on applications with these webinars. I'm a bit conscious of time now, but certainly I can see a lot of questions, which is really good to see. So do keep up all your hard work with your applications, and then you can talk about these things that you've done at interview. You can talk about having done a study guide, doing a PBL case written by a junior doctor, and then gone through it in the webinar session. That demonstrates incredible commitment. You've already experienced a little bit of what medical school will be like, because you do have PBLs at medical school. They will, or and similar teaching techniques at dentistry and veterinary. This is a new style of learning that they like you to use, because it helps you to teach yourself basically and learn as a group. And the SJT, their ethical professional principles all the way through. In the next webinar, where I'm actually going to join up with a couple of experts in medical ethics, and they're going to bring in a little scenario on like an ethical case in medicine, which is very, very common. We do commonly face them, and sometimes they do challenges, and they challenge a team of doctors. So if you're already thinking about those things, you are so well ahead of the curve. Like you guys are doing so well to be involved in this, to be watching this webinar. And I hope that you can always look back at this, look back at the case. Any questions you have, just email me. My email is vpeducation@medicmentor.org. I don't get very many emails from you guys with questions, but I really want your questions. I really want to help you. So please do. Now I'm going to sign out now, and I'm going to see if Sherry Ann is available. I think we're having a few problems sharing slides, and we've decided we're going to try and find a way to basically that we can all be on at the same time and share our slides. So I really hope that we'll have oh, I've just seen Sharon's message. Lauren, yeah, okay. Oh, I see. Sherry Ann's having problem logging in. Okay, I'm going to sign out. Please hold on. Sherry Ann is a fantastic speaker. She's just going to tell you a little bit about the veterinary side in this and about sort of management of new puppies. So for all you, for One Health, which is what we're doing tonight, I'm going to hand over to Sherry Ann, our veterinary VP. And thank you very much for joining. Our next webinar, our next study guide will be out in the next sort of week or two. And then the webinar will be at the end of the month, so make sure you join us. And to all our vets, enjoy especially the next bits, and I wish you all the very best. So thank you very much. Good night.